Kwan.
Yes, good morning. Thank you, Preeti. Certainly a great welcome again to our friend and colleague across the globe and across the United States for joining us. I have a very great pleasure of moderating this session with Dr. Yasir Seba, who is currently Assistant Professor of Ophthalmology at the Bayer Institute at Stanford. As we have seen over the last decade or so, we are now treating many of our patients by delivering drugs to their eye to various ways, either around the eye, inside the eye, or underneath the retina. So certainly we have been facing a lot of challenges with various aspects. And we like to dedicate this session this morning on delivery challenges for our retinal therapeutics. And to start our session today, we will have Dr. David Brown from the Retina Consultant of Houston. Now, throughout the world of retina, certainly the name David Brown associated with outstanding, excellent work in retinal diseases in many, many clinical trials that David had led throughout the years and decades. Today, he will deliver a talk on intravitreal drug delivery challenges. But I want to call out a very, very special thing about David today. And right now, live, Dr. David Brown is actually like Steve Martin, because today he will be father of the bride. And it is with tremendous, tremendous pressure and appreciation that we have David with us, even though he will be walking down the aisle with his daughter later on today. So David, congratulations and welcome to this year, 2022 Innovate Retina.
Thank you so much, Kwan, and for allowing me to participate in this talk. Maddie's getting married at 2:30 Mountain Time, so please have your thoughts with us. They gave me a pretty challenging talk for the first talk of the morning, viscosity, which is given the Greek letter eta, ETA, in all the equations, and intraocular drug injection issues. The question is, if you increase viscosity, is that a problem and how can you overcome it? This is particularly important, as you know, if you've used the newly approved faricimab, it's much more viscous than ranibizumab, so it's harder to inject. The Apellis drug, pegcetacoplan, is even more viscous. The 8 milligram aflibercept that's currently in trials is very viscous as well. It's actually 8 milligrams and 0.07 because of solubility issues. That's the most they could put in. So one way you can deal with it is to go larger volume, which, as we know, can cause intraocular pressure rises. So what we're going to talk about today primarily is viscosity. This is Poissier, and he's a French 1797 to 1869. And Poissier's law basically determines how flow rate or volume flow rate, which is change in volume over time, relates to these various things. And interestingly, flow rate equals pi times the pressure difference between the end of your tube and the beginning of your tube, times the radius to the fourth, which means that the size of your needle is the most important thing. That's over 8 times eta, which is our viscosity, times the length of the tubing. And so we're going to talk about how you can think about these things to, once you get an ocular therapeutic, how do you put it in the eye? And are there some tricks to get there? So this is a nice cartoon showing you the main factors. And so the length of the needle is directly proportional to the ability to the pressure to push it through or the volume resistance. The radius to the fourth is even more important. So you increase the internal diameter of your needle, it's much easier to push a viscous fluid through. So when ranibizumab first came out, I was actually doing it not for viscosity, but for patient pain. I got TSK to create the 32 gauge, 11 millimeter and 9 millimeter needles. In other words, shortening the needle gave me two things. It made it less flexible, so it didn't flex with that thinner gauge, but it also allows you to push a more viscous fluid through. TSK makes fantastic needles out of Japan. Japanese bioproducts, which counterintuitively is from Korea, basically knocked it off and actually makes a very good needle now. And so if you're looking at very thin walled internal diameter needles of various lengths, both of these companies make excellent products. So what else can you do? You want to make sure, even with the faricimab drug, you use a Lure-Lock syringe, because if you have any kind of pressure resistance with a Lure slip needle, you can project the needle off of the syringe, and it's frightening for both you and the patient. So ideally, you get a Lure-Lock syringe. Almost every needle we use has a Lure lip on it, so it will work with the Lure-Lock. But you want to make sure that if you're using any of the drugs that are more viscous than you're currently used to. The last thing I'm going to talk about is increased temperature. And you don't have a whole lot of options of this, but this is honey on the right. And we all know that cold honey is way more viscous than warm honey. So right when you pull the drug out of the refrigerator, it's going to be harder to inject than if it sits there a while. Obviously, all drugs have different temperature tolerances, so you certainly don't want to warm it up just to decrease the viscosity, but it's certainly something to think about. Increased temperature means decreased eta, or decreased viscosity. So I left my talk short and sweet, because if you have any more French equations, I'm sure you'd need more coffee than most of us have had. Thank you very much.
Thank you, David, for a great start here. And now we will leave the question and discussion after our speaker gone. And now, yes, you will introduce our next speaker here.
Thank you, David. It is our great pleasure to welcome Dr. Leila Vesovich. She's an associate professor of ophthalmology and director of the Duke Vitreoretinal Fellowship Program at Duke Eye Center. Dr. Vesovich is known nationally and internationally as an outstanding vitreoretinal surgeon and for her work in vector-based and gene therapy. Today, she will discuss with us the surgical approaches to viral vector-based anti-VEGF therapies. Leila, take it away.
Thank you, Asir. Thank you for that kind introduction, and thank you to the organizing team for inclusion in this fantastic program. It's an honor to be included with David Brown and Jack Wells as well in this presentation. These are my disclosures, and I will mention I am a lead PI at Duke for several REGENXBIO clinical trials, as well as a lead clinical trial PI on phase 3 pivotal programs such as ASCENT for REGENXBIO. Gene therapy represents the therapeutic delivery of nucleic acid polymers into patient cell. It is a particularly suitable target because of the immune privilege, blood ocular barrier, ability for us to visualize, access, and locally treat the cells, and minimal vectors needed to really inject in the eye. In 2017, FDA approves the first human gene therapy, the first AAV vector therapy, which all of us are very familiar with. And this has sparked significant interest in development of gene therapy agents. And to date, we have a tremendous pipeline for IRDs as well as common retinal diseases. Tools for gene therapy delivery include, and most commonly is the viral vectors, the AAV vector particularly, because it does not alter the patient's native DNA, it lacks pathogenicity, it has multiple available serotypes, and it does have long persistence despite low integration frequency, and it causes minimal host immune response. So there are several approaches to gene therapy delivery, and they are nicely overviewed here. We're going to dive into the first one, the suprachoroidal space. This is a novel way of us delivering drugs in general. It does target It has a targeted access to suprachoroidal space, and it is a way to transduce retinal cells with minimal exposure to vitreous and anterior segment. It does lend itself to intra-office or in-office procedure and potentially has a way of us delivering gene therapy widely. The second approach is the gold standard currently, the subretinal space delivery, which is a in operating room type of procedure. It does deliver drug to a compartment, subretinal space, and as such, it has minimal exposure to vitreous anterior segment. It leads to very low immune response and very low risk of inflammation. So as I mentioned, this is currently the gold standard and the way it's approached in several clinical trials. The last approach is the intravitreal approach, the vitreous chamber. It is, again, what we're all used to doing very much in office. So it's an injectable form. It does have some limitation. Because of the ILM, there is a decreased transduction of the retina or retinal cells per se. It does lead to higher risk of immune response, inflammation, and there's a need for prophylactic corticosteroids because of the broad exposure to the vitreous and anterior chamber. And there are several clinical trials on the way. Particularly, I'll be emphasizing on RGX-314, which uses a novel AAV8 vector, which delivers an anti-VEGF Fab similar to ranibizumab. There are several programs in this category, the subretinal particularly, which is for neovascular AMD, and then suprachoroidal, which also targets AMD as well as DR. Looking at subretinal delivery particularly, the phase 1/2A trial has completed and had fully enrolled 42 patients. Currently, these patients are followed long-term, and the learnings from this trial showed us that the RGX-314 is a long-term durable treatment with effects being seen at 2 and 3 years out, with effects on visual acuity, retinal thickness, and decreased anti-VEGF treatment burden. Overall safety from this trial showed that it is well tolerated. There were no reports of inflammation, intraocular inflammation, but there were reports of RP changes, particularly in higher cohorts groups. These RP changes did affect vision in 2 patients. The results from this from phase 1/2A trial that has now feeding into pivotal program showed that, as I mentioned, it's well tolerated with no need for prophylactic steroids. The blebs, since the learnings of RP changes, are now being made inferiorly to minimize the risk of RP changes in the macula. The higher cohorts groups, 3 to 5, do show durable treatment effect. And there was really no influence of antibodies on the delivery or persistence of this protein in the eye. So hence, the pivotal programs have started. Atmosphere and Scent, these are phase 3 clinical trial that aim to enroll 300 to 465 subjects across the nation. It is meant to show efficacy, safety, and tolerability, and overall compare between ranibizumab and aflibercept. The trial design itself includes first-time injection, followed by response, and if a patient did show adequate response, the patient follows with a subretinal administration of gene therapy. And it is being followed and assessed for not only efficacy, safety, and tolerability, but potentially for the need of recurrent injections. Now, diving a little deeper into the surgical procedure itself. The steps of this approach include vitrectomy, which we are all very familiar with, subretinal drug delivery, which we'll specify in a little more detail, and then really post-op follow-up is pretty routine. The preparation with any surgery is the key. And here particularly, I like to very much review all the photographs that were obtained as part of the clinical trial. I like to really think about the targeted zone. For us, it will be inferior retina, and propose injection sites. I'll even go to the extent of printing out images and labeling them on the day of the surgery to make sure that I have this well kind of understood and planned. The next step is this trial does require use of a 23-gauge blunt cannula. And I like this cannula because it is an extendable 41-gauge polyamide injection needle. It allows me to kind of moderate the length of the needle, and longer needles sometimes allows to a little bit more flexibility and tension delivery to the retina. But also it is retractable. So as I'm inserting it through a valved system, I'm not going to have too much trouble bending the potentially needle. The next step is really connecting it to automated session, which is the Med1 connector you see in the images here. And I like to test this right before and set it up all before the surgery started, because you definitely don't want to be struggling as you've done your vitrectomy and done other steps of the procedure to be playing with this. And lastly, I will actually go through the extent of loading the drug and preparing it for the delivery. Next slide, please. Here you will notice that now we're performing parsplane vitrectomy. We are initially delivering some samples of ACM vitreous, which were part of the clinical trial, but really the vitrectomy portion is very routine, like as you typically see. We do like to use judicious use of triesence or Kenalog to help us highlight the vitreous and remove it as thoroughly as possible. And the next step, which is a little bit out of sequence, is doing peripheral shaving and identification of retinal tears and treating them at that time to minimize the need for doing that later on. Once you have created a blood, you do not want to be placing any additional pressure or changing infusion pressures as you are doing your depression. The subsequent steps and the most critical is the subretinal injection. I find while the injection itself has its tips and tricks, really, unless you took the time to decrease intraocular pressure to 10 to 15 millimeter mercury, you will have the hardest time delivering drugs subretinally, because you have this intraocular pressure that's resisting you adding any additional fluid, especially in subretinal space. So first thing to do is lower your intraocular pressure, turn off your IOP control settings if you do have that on your machine, and then make sure that you lower your intraocular injection rate using the automated settings on viscous fluid inject to at least 16 millimeters mercury. Next step is to direct your needle to the location and really slightly touch, cause slight chordal blanching at the time of the delivery. I like the extended needle to the fullest degree, because if that needle starts to bend even a little amount, I know that I'm placing significant pressure at a time, and that should be enough alone. I do like to use intraocular OCT to help me make sure it's truly in subretinal space, not in sub-RPE, or maybe not even creating retinal schisis, which we can definitely see in some of these gene therapy deliveries. And lastly, once we've successfully delivered the drug in a very slow, steady rate, I like to do that about 4 to 6 psi millimeters mercury, and do that over a minute to even 3 minutes, depending on what the volume needed to be delivered. We will proceed with fluid exchange and removal of entire access of the virus that might have gained the vitreous cavity during the procedure. So key takeaways here are: be very thorough at preparation, the setup of subretinal injection apparatus, the preparation of drug itself. The next step to complete vitrectomy is something we're all routinely used to, but be mindful to include examination of retinal periphery before you deliver the subretinal drug. Next, lower your intraocular pressure to be at least 10 to 15 millimeters mercury. And then be mindful when you're delivering the drug, it's going to be in inferior retinal location. So summarize for you, gene therapy represents an emerging and promising therapeutic approach to delivering the drug, not only in rare, but common retinal pathologies. And we hope that this approach will be sort of a one and done treatment approach, addressing the treatment burden that currently exists. And with any surgical procedures, preparation is the key. And I hope I covered some of the key steps for you as you're thinking and proceeding with these deliveries. Thank you so much for your time.
Thank you, Leila, for that wonderful presentation. I think there is a question or two waiting for you in the chat, but we will take some questions towards the end of the session. Kwan, is that the plan, right?
That's correct.
All right.
Wonderful, thank you.
Now to our third presentation in this session. So certainly during the past few months, the world of retina again will wonderfully welcome another treatment for our patient with neovascular diseases and also retinal vascular diseases, and that is faricimab. So Dr. Jack Well, who's an outstanding clinician scientist, have led many different clinical trials, will share with us a discussion on a very important question: is the new treatment, new drug faricimab, more durable treatment of neovascular AMD and diabetic macular edema? Dr. Well is from the Palmetto Retina Center, which is part of the Retina Consultant of America. And we're very, very pleased to have him with us this morning. Jack, welcome.
Thank you very much, Kwan. It's a real privilege to be a part of this session. These are my disclosures. So it's been disappointing for all of us to learn that real-world outcomes of anti-VEGF therapy for wet AMD and DME are inferior to the results of randomized clinical trials, presumably because the burden of frequent injections is unsustainable for patients, their families, and our clinics. And so industry has responded to that by looking for more durable treatment options, gene therapies, as Leila just reviewed, sustained delivery devices like the PDS, and faricimab, which is recently approved by the FDA this year for the treatment of AMD and DME. And the pivotal phase 3 trial results were published in the Lancet for the AMD studies and the DME studies back in January. So I just wanted to review these study results, and then we can talk about whether it really is more durable. So Genentech identified the angiopoietin Tie2 signaling pathway as an attractive target. In healthy tissues, angiopoietin-1 binds the Tie2 receptor and is important for the maintenance of a normal, healthy vasculature. But in pathologic states, such as AMD and DME and RVO, upregulation of angiopoietin-2 competitively binds the Tie2 receptor and leads to vascular leakage, leukocyte migration, and also potentiates the pro-angiogenic actions of VEGF-A, which is also being upregulated in these pathologic states. So faricimab is the first intraocular bispecific antibody, which has 2 Fabs, one binding angiopoietin-2 and one binding VEGF-A. And the hope is that this combination of inhibition would lead to more durable therapies. So let's look at the AMD studies first, Tenaya and Lucerne. These were large phase 3 trials done worldwide, and they randomized patients to either faricimab 6 milligrams or aflibercept 2 milligrams, but the treatment protocols were quite different for each agent. Aflibercept was given in 3 monthly doses and then every 8 weeks per its label through 2 years, whereas faricimab was given in 4 monthly doses, and then a sham injection was given at week 16, and then at weeks 20, 24, and 28, there was an assessment of the presence or absence of disease activity. If there was activity identified, an injection was given. If not, it was deferred up until 16 weeks, where an injection was given whether there was activity or not. So once this interval was determined during weeks 20, 24, and 28, that eye received injections at that interval for the remainder of the study. And importantly, there was no rescue injections permitted. So, as I mentioned, these were large studies, over 660 eyes in the pooled data in each arm. They were well balanced with respect to baseline vision and baseline central subfield thickness. And the results that we saw were really at 1 year, there was no difference in the average gain in visual acuity between the 2 treatments. It was about 6 letters. But in the faricimab group, 45% of the eyes were on a Q16-week dosing interval at week 48. Another 33% were on a Q12-week dosing interval at week 48. So almost 80% of eyes were on a Q12-week or greater dosing interval. Other visual parameters were also equivalent. About 20% of eyes in both groups gained 3 or more lines of vision, and very few eyes lost 3 or more lines of vision. Almost 60% of both groups were 20/40 or better at week 48, and very few eyes in both treatment arms were 2200 or worse at week 48. Anatomic results were also similar between the two groups at 1 year, about 130 micron reduction in central subfield thickness with either treatment, though we do see the sawtooth pattern that we've seen before in other studies. These are just some representative case examples of an eye that with subretinal fluid at baseline that was dry at week 16, and then at the week 20, 24, and 28 disease assessments, there was no fluid, but the patient was treated at week 28, and again 16 weeks later remaining dry. This is a little bit different. This eye had a substantial amount of subretinal hyperreflective material at baseline, but at week 16 looks pretty dry. No activity at week 20 or 24, but at week 28, there was recurrent edema. So again, this eye was treated at week 28, which was 16 weeks, and again, 16 weeks later. So basically, through 1 year at least, faricimab gave equivalent vision and anatomic outcomes to aflibercept at a much less frequent dosing interval, 45% at 16 weeks and almost 80% at greater than Q12 week dosing. But again, aflibercept was given at a fixed interval with no alternative for flexible dosing. So looking at the DME studies, Yosemite and Rhine, again, eyes were randomized to 3 different arms. Aflibercept was given per label 5 monthly injections and then every 8 weeks through 2 years. Faricimab also had a fixed dosing arm with 6 monthly injections and then every 8 weeks. But the important arm to focus on was this personalized treatment interval, or PTI arm, which was given 4 monthly doses. And then subsequent injections were given based on assessment of the vision and the central subfield thickness. So in the PTI group, 4 initial injections were given, and then monthly dosing was continued until the first achievement of a central subfield thickness of less than 325 microns, which was the threshold for definition of DME. And then subsequent to that, if the eye was continuing to improve in terms of vision or CST, the interval was maintained. If the eye became stable, the interval could be extended by 4-week increments up to 16 weeks. But if the vision or OCT were worsening, then the interval could be reduced by 4 or even 8 weeks for more severe worsening. As in the AMD, large trials with over 900 eyes in each study, well balanced at baseline in terms of vision and central subfield thickness. And at 1 year, there were equivalent vision improvements with all 3 treatments, about 11 letters in both studies with all 3 arms. And this was sustained through 2 years, really no reduction in efficacy was seen. At the 1 year time point, half of the eyes in the faricimab PTI arm were on Q16 week dosing and another 20% were on Q12 week dosing. And only 7% of eyes were on Q4 week dosing through year 1. So remarkably, in the second year, this was sustained. In fact, it was improved. Over 60% of eyes were on 16-week dosing at 2 years, and another 13 to 18% on Q12 week dosing. So about 80% of eyes were on a Q12 week dosing or longer at the 2 year time point. In the second year, the PTI arm got a median of 3 injections versus 5 in the other 2 groups. And about 80% of eyes that achieved a Q12 or 16-week dosing in the first year maintained that dosing interval through the second year. Other visual parameters were also equivalent between the 3 arms. About 35 to 40% of eyes gained 3 or more lines of vision. Very few eyes lost 3 or more lines of vision. And the anatomic improvements were slightly better in the faricimab arm at year 1, though this difference narrowed at year 2 with a good reduction in all 3 treatments. There was also more absence of DME in the faricimab groups compared to aflibercept, though it was good in all three. And more faricimab treated eyes had resolution of all OCT intraretinal fluid. Also, there were similar improvements in diabetic retinopathy severity score in all three arms. So essentially, we saw the same thing in the DME studies. We saw comparable visual and anatomic improvements with faricimab compared to aflibercept with reduced dosing. So is faricimab more durable than aflibercept? Well, as I mentioned, there was no head-to-head comparison because aflibercept could not be dosed less frequently than every 8 weeks. In my experience, at least, I rarely see aflibercept eyes in my practice go 12 to 16 weeks between injections. So it seems like it might be more durable in AMD, but I really think the 2-year results are going to be the proof in the pudding, and we don't know those yet. Be interesting to see if that's maintained. In DME, it seems like it may be more durable by comparison. In Protocol T, eyes in the aflibercept group were given 9 injections in year 1 and 5 in year 2, which was more than in these faricimab arms, which was 7 in year 1 and 3 in year 2. So it's going to be very interesting to see if these results are replicated in clinical practice. Thank you.
Thank you, Jack, again, for enlightening us with amazing set of data here. So at this time, we are going to open up our panel discussion here. So we will have everyone back online, feature Dr. Seba, Dr. Brown, Dr. Flashovich, and Dr. Wells. So we will start out first with some of the questions that already in the chat, but it would be great to hear Dr. Brown here. So David, there has been some question for you in terms of using the different type of needle that can lead to either increase in intraocular pressure or increase in the amount of discomfort for the patients. Can you comment on those, please?
Sure, a couple comments. One, intraocular pressure really shouldn't matter on viscosity. It does, though, if the viscosity of your drug makes you have to use a larger dose. In other words, the 0.07 mils of the aflibercept 8 milligram dose obviously is going to cause more transient intraocular pressure rises than the 0.05 of any drug. That being said, if your drug migrates to the anterior segment, a more viscous drug might cause more issues with the trabecular meshwork. The other question is, I said I went to the shorter needles with a finer gauge for pain. That really depends on how little topical anesthesia you use. Many of my partners use subconjugal lidocaine, so then you can probably use the 17 gauge trocar. I typically try to get by with less pure topicals so that they don't get the subconjunctival hemorrhage. What's most important actually is not necessarily the size of the needle, but how sharp it is and how it goes through the eye. And so I tested a bunch of different needles. I didn't want silicone on the inside, but the outside of the needle has to be siliconized or you really can't push it through the sclera easily. So even the short needles, don't hesitate to use a siliconized needle because it's less pain.
That's great. So that brings out a lot of the safety concern that we have with that. That's great. You see any comments, any thought from you see anyone?
Yeah, I think there is a question for Leila. So Tina is asking, in phase 2 RGX-314 AMD trials, there were pigment changes, depigmentation at the inferior around the bleb. I'm curious of how such pigment changes have evolved thus far and in long-term 3 to 5 year post-op.
I think that's a great question. Thank you for asking and bringing that up. So just to kind of remind everybody, phase 1/2A trial, RGX-314 was a dose escalating trial with 5 cohorts. The cohorts 3 to 5, the higher dose cohorts, did show RP changes. And the higher the dose, the more RP changes or the more severe RP changes we did see. The procedure for that trial actually involved us creating injection in superior portion of the retina above the superior arcade. And it's thought that, with time, there was migration of fluid inferiorly, and the changes, did reach or were seen in the macula as well. They do continue to progress over time, and they're actually seen typically more few months to years out from the procedure. And really cohort 5, the highest dose cohort, is the one that we saw the most severe changes that affected the vision. 2 patients had severe visual loss related to that. So the pivotal program has chosen a lower dose cohort. As a result, it was equally effective, actually very effective, but with minimal changes from that. And the procedure was adapted to inject now fluid in inferior retina, with the idea if we do see these RP changes in this cohort, it would be affecting inferior retina and not potentially affecting vision. But overall, there were significant learnings from that trial, and the lower dose was chosen for that reason, and really minimal changes from the RP pigmentation were seen in that cohort. So I think phase 3 will show us the rest of it. I think it's also interesting to find out or see that there are other clinical trials out there with gene therapy delivery. They're seeing RP changes as well. So I think, even Luxturna delivery, the currently approved, FDA-approved gene therapy delivery, we're seeing reports of macular, RP atrophy loss years out from the treatment. So I think, this is a very novel way of us treating disorders. I think it's very promising in terms of one and done approach, but it's much to be learned and much to understand, what are we doing as we're transfecting these cells, what is being hypertrophied, what is growing, what's causing RP changes, and how is that all going to result at the end.
Leila, so piggybacking on what you just said, is it, what do you think, do you have any hypothesis as to why the RPE loss occurs? If this is across the board for multiple gene therapy indications, then why is the RPE exhausting in some way, shape, or form? Or what exactly?
Yeah, well, we are definitely, we are transfecting these cells, RP cells. And my hypothesis or idea is that we are causing changes. There may be growing, hypertrophying the cells and causing more pigmentation, and hence you're seeing that as well. But we're definitely making changes in the RP at the RP level itself. So long-term, how is that being affected? I think one is to yet know, but yes.
Thank you, Leila. Before we go to Jack with some of the questions, let's go back to David for here. So some of our new treatment come out, as you mentioned, whether the faricimab or if Regeneron go on further with the 8 milligram dosage because of increase in viscosity. Do you think it would be good for manufacturer like either from Genentech or Regeneron to now supply us with the new treatment, but with now a needle that go to every package? So that way it would get all of us be ready, or what do you think of that, Dave?
Yeah, so there's a lot of challenges in that. And one of the main challenges is every doctor has their own way of cooking their soup. In other words, there's doctors that do subcutaneous lidocaine that look like bigger needles, smaller needles. And so I think it would be challenging. If it was pure viscosity, an injection pump, like a micro injection pump, like Stephen Smith has worked on, it would solve that, because with an injection pump, even a miniaturized the size of a needle, you could push anything through even a very small needle. Most manufacturers have rejected putting things because everything has to get FDA approved, and you have to have supply chain issues that you keep constant. And so, especially with the supply chain issues we've seen, I think most manufacturers will be hesitant to recommend a special needle.
Thank you, David, for sharing. So before we go on, I would like also to recognize some of our fellow working behind the scene, the suppliers who are the question. For this session, we have Dr. Kapil Mishra, who is our second-year retina fellow, coming from us from Wilmer, and will be returning to Wilmer's very shortly to become Assistant Chief of Service. And in addition, this morning, we also have Dr. Suzanne Mikalak, who is our first-year retina fellow, and Suzanne's actually coming from Duke from us, and she's been doing outstanding work as well. So with that, let's go on to the next part for Jack. Jack, certainly many of us have seen the outstanding data from the 4 pivotal trial with faricimab for both neovascular AMD as well for DME. Now, we have not seen an improvement in the overall visual acuity. We, however, have seen, and you have shown changes in terms of durability of this aspect. Do you think, and share your thought, do you think that the changes, that the improvement of the longer durability is due to the fact that indeed there are two targets with this drug, for us, with Ang2 as well as VEGF, or do you think that the design of the trial that have led to such differences that we see?
I think it's more likely that the design of the trial is showing us this. I mean, they haven't released the 2-year results for AMD yet, but I've seen them. And a majority of eyes do continue on 16-week dosing, but there is a smaller group of eyes that does not do well over time with 8-week dosing. And, one of the remarkable things about the AMD studies was that they didn't allow rescue therapy. And so, you were stuck at 8 weeks, even if you weren't necessarily doing well. I think, the way they did the AMD study, where you established a treatment interval early on and maintained that interval through the end of 2 years, really kind of regardless of what was going on, they set it up so that, the AMD, the faricimab eyes were probably going to get fewer injections. So I think the jury's out in AMD, at least. In the DME case, I do think there's some reason to believe that maybe there's some synergistic effect of that angiopoietin-2 inhibition, because I think it was more real, the improvements there. Though if you look at the DME studies in the faricimab fixed Q8 week arm, the anatomic outcomes were actually better than in the PTI arm. So I don't know if it's a 16-week drug necessarily, but it seems like there may be some additional benefit of the angiopoietin-2 inhibition, because you had better reduction in edema in the Q8 week arms than aflibercept. So that's what I think. I think it's different depending on the disease.
David and Leisha, have you had an opportunity to use faricimab in your patient yet? And among the three of you, for your own patient, have you noticed any difference? You can start with David or first.
Who's the question to?
To you, David. So have you used?
Oh, sorry about that. Yeah. So it's really too soon. We're switching our patients that have fluid on aflibercept, and I think it's very unlikely that they're going to go much longer. I'd just love to dry them up more, and so that's what we're attempting to do. If you look at the FDA labeling, not the labeling, but the FDA filing, you see that the average half-life of faricimab is 8 days. So if you assume primary order kinetics, most of the drug is going to be gone in 40 days for the average patient. So I'm a little skeptical that it's going to go out to 12 or 16 weeks based on that. But the jury's out. We'll see, just like Jack said.
Leila, any from you?
I practice in university setting, and as such, outside of clinical trials, we actually have not used it in clinical care yet. We just got faricimab approved actually this month, so I look forward to trying it.
So Quan, I just mentioned real quickly, I've been using it much as David has been doing. I have only patients with persistent fluid on aflibercept, but unfortunately to date, we haven't been reimbursed for any of it. So I don't know how much longer that's going to take.
They get their permanent J code in October. That'll help the reimbursement issues, right?
Yeah, right.
Yeah, that's a very important. So great. Do you see any additional question that we see as you see?
No, I think that there is a conversation going on in the Q&A section right now, and people do appreciate that the suprachoroidal delivery for the RGX or any other gene therapy would be better. So Leila, if you could just comment on why do you think the suprachoroidal, other than the safety, better safety profile, do you think it has additional advantages of somehow distributing the workload for these cells to be making protein in some way, shape, or form? Would it be better?
Yeah, I think the biggest advantage would be in-office procedure, making it really widely available for all. I think the second advantage it does, like as you follow the injection drug, and particularly animal models have shown it definitely diffuses posteriorly and throughout like anterior and posterior pole. So the thought is it, will be transfecting the retinal cells without really minimal invasion of the vitreous and anterior chamber space. That said, in clinical trials, we also have seen that there's minimal use or minimal need for any type of steroid treatment, even topical. So that's been a very interesting learnings from the ongoing phase 1/2A. So I think it seems to be promising. It's a very novel way, and I think there's much to be learned yet. But so far, I think advantages would be as such in office and minimal really complications relating to surgical kind of approaches. So.
Thank you.
Thank you, everyone. Certainly, we have a great discussion so far, but we're time's up right now. So I would like to thank again, Yasir and I thank you very much to our three outstanding speakers, Dr. David Brown, Dr. Leisha Vatrovich, and Dr. Jack Wells, for leading us with this morning session. And now we are moving to our session number 2 that will be led by Dr. Doe and Dr. Lucian Leong.
Good morning, everyone. I think I can be heard. I'm hopefully. So in our next session, we'll be discussing some of the newest and latest late-breaking developments in gene therapy and the treatments of AMD and IRD and other conditions. My name is Lucian Leong. I'm a vitreoretinal specialist on the faculty at Stanford. I'm really excited and honored to be part of this session. My co-moderator for this session is Dr. Diana Doe. She's a professor of ophthalmology at Stanford and my colleague in the retina division. Diana will be introducing our first speaker. Diana, you want to take it away?
Thank you, Lucian. It's my pleasure to introduce our first speaker for today's session, Dr. Nancy Holdcamp. She's professor of ophthalmology at Washington University in St. Louis and director of the retina division at the Pepos Eye Center. Nancy is a true leader in clinical trials, and she'll be giving us an update on complement factor I in gene therapy. Nancy?
Thank you, Diana. It's such a pleasure to be here, to be part of this meeting and this session. It's a privilege to present the first in human experience with GT005. It's an investigational AAV2 vector in patients with geographic atrophy. These are my disclosures. Importantly, I get consulting fees from Gyroscope, and I am a participant in the FOCUS clinical trial that we will be discussing. So it's pretty well established now that complement inhibition is a validated approach for geographic atrophy. We have seen clinical trial results that show that inhibiting C3 and C5 can slow the growth of GA in study patients. And so the question is, why target complement factor I? Well, complement factor I, or factor I, is strongly associated with the development of AMD. And we see on this graph here that people with CFI rare variants have a higher risk of advanced disease and have low factor I serum levels. Now, the key word here is rare. We know that these rare variants that confer a very high risk are indeed infrequent in the population, maybe 2 to 4%. So it begs the question, what about the overall AMD population? And this may be one of the most important slides that I show. The graph on the left shows that factor I supplementation may reduce complement activation regardless of the underlying genetic risk. In fact, an 80% increase in factor I converts high-risk complement activity to low-risk complement activity. And it's common among people who really understand the complement system that they believe that there are risk factors and there are protective factors, and that protection can often trump risk. So that brings us to this very familiar complement cascade. And the hypothesis being tested in the early phase clinical trials is that inducing factor I expression will lead to continual sustained decreases in key proteins involved in the complement overactivation. And you see the complement byproducts in red here. Those should actually decrease in the vitreous if complement factor I supplementation is being effective. And we will come back to this later. So gene therapy, this is the structure of GT005. It is an AAV2 based gene therapy designed to induce expression of factor I, and it's packaged into an AAV2 vector, which transduces the cells. And as is common with other forms of gene therapy, in our space, we are creating little biofactories of complement factor I, which is a secretory protein. So why gene therapy? Well, we know that the complement system is always turned on, and we could combat it with monthly intravitreal injections, which represent a pulsatile intermittent high dose of drug exposure and certainly requires a high treatment burden. So gene therapy is designed to provide a durable effect with a single administration, hopefully a one and done type scenario. So this is the FOCUS trial. It is the design of the phase 1/2 open label GT005 safety and dose response trial. I'll be reporting the interim safety and biomarker data for the first 4 cohorts, which include 31 patients. Please note that all of these patients underwent vitrectomy surgery with subretinal transvitreal delivery. However, in the FOCUS study, there are cohorts 5, 6, and 7. Those are fully enrolled. We're collecting data, but please note that those patients did not receive a vitrectomy, but rather a new surgical technique for delivering gene product into the subretinal space called the Orbit subretinal delivery system. So here are the results. Again, an interim safety analysis from March of 2022. Totaling 31 patients. And first off, GT005 appears to be well tolerated. There are no serious adverse events related to GT005 and no safety signals on the laboratory parameters. There are some RPE changes noted in some subjects in the high dose group, but restricted to the bleb area with no significant visual changes. This is similar to what we've seen in other gene therapy programs. When we look at treatment emergent adverse events, most are surgery related, most are mild. When you look at the moderate TEAEs, we see that 6 of them were cataract, not unsurprising in this age group of patients, but there was one intraocular injection complication where the gene product was delivered to the sub-RPE space. The interim data also shows no clinically significant GT005 related inflammation. And I just want to draw your attention to the type of immunogenicity data that's now being collected for gene therapy studies. We're looking for AAV2 neutralizing antibodies, both pre-existing and any rise in titers. We look at pre-existing T cell immunogenicity to the vector and then any rise in titers. We look for anti-CFI antibodies. None have been seen to date. And we look for AAV2 vector shedding, and again, none has been detected to date. So back to this cascade of the complement system and our hypothesis, if complement factor I supplementation is effective, then everything we see framed in a pink box should decrease. What we see from the biomarker results is that vitreous levels of factor I go up through week 56. In the middle panel, we see that vitreous BA and C3b and IC3b levels go down in a sustained fashion through week 56. And then because we're decreasing the overall inflammatory insult to the eye, We see that the vitreous C3 levels also decrease. When monitoring for any effect on serum plasma complement factor I, we see really no change. And we also see that the elevation in aqueous factor I mirrors the elevation in vitreous factor I as well. So the take-home messages are that GT005 is a potential one-time gene therapy targeting complement activation. And so far in a small number of patients, it's been well tolerated with increased factor I levels in the vitreous and downstream biomarker reduction. And randomized controlled phase 2 trials evaluating safety and efficacy of GT005 are currently ongoing. And I'd like to acknowledge the study participants, all of the principal investigators, as well as the study teams. Thank you.
Thank you, Nancy. I wanted to introduce our next speaker, Dr. Rahul Khurana. He's a vitreoretinal specialist at Northern California Retina Vitreous Associates. He's also an associate clinical professor at UCSF. And in addition to being an excellent clinician and surgeon, he's for many years been heavily involved in clinical research, ophthalmology advocacy, and education. We're very lucky and fortunate to have him talk to us about suprachoroidal RGX-314 data review and next steps. Rahul?
Thank you, Loshan. Thank you, Diana, for having me this morning. I'm very excited to give you an interim update on the suprachoroidal RGX-314 program. We're going to go over both the AAVIATE and Altitude clinical studies and talk a little bit more about the data. Here are my financial disclosures. Of note, I've served as an investigator and received research grant support from REGENXBIO. Now, we've already discussed about the optimal space for gene delivery. Leila brought up some really good points, and we know the vitreous chamber is something that we're very familiar with. We're very comfortable with intravitreal injections. However, there's a broad exposure to the anterior segment and the vitreous, which can lead to more complications. On the other extreme, there's a subretinal space, which leads to a more targeted delivery, which appears to be more safer, however, requires a more invasive option, requiring often a vitrectomy and going to the operating room. The suprachoroidal approach is a really exciting area because we can have a targeted delivery with very low exposure to the anterior segment and the vitreous, which theoretically could lead to a safer approach. And more importantly, it's something we can do in the office and allow ultimately the gene therapy to be more accessible. Now, we've talked a little bit about RGX-314. As a summary, it utilizes an AAV8 vector that has the potential for long-term protein production with minimal inflammatory response compared to previous generational AAV8 vectors. Now, RGX-314 encodes for a gene that allows for the potential for sustained protein production by the retina's own cells, as many people have talked about, converting the eye into a biofactory. Now, we're going to look first at the AMD program, or AAVIATE, which was a phase 2 clinical trial that took patients who were previously treated who had active disease, who were then randomized to either receive monthly ranibizumab or a one-time suprachoroidal injection of RGX-314. Patients were then followed over the next year and treated as needed. Now, it's important to note that no prophylactic steroids were given throughout the study. And today we're going to talk about the 6-month interim data from cohorts 1 and 2. As you can see, the route of administration for the gene therapy in AAVIATE is through a suprachoroidal approach, and it's important to note that phakic patients were also included in the study. When we looked at the baseline characteristics of the patients entering the study, you can see these patients actually had very good visual acuity. They average about 20/30 to 20/40 visual acuity, and they've been treated for about 2 years, and they averaged about an injection every 5 weeks. So these are patients that we're basically treating almost monthly who are enrolled in the study. When we looked at safety, RGX-314 was well tolerated in cohorts 1 to 3. There were 4 SAEs, but none were considered drug-related, and there were no cases of chorioretinal vasculitis or occlusion, nor hypotony were observed. Now, intraocular inflammation is an area of concern, and you can see there was a very low rate of intraocular inflammation, only 4 cases in cohort 1 and 3 cases in cohort 2, as well as 3 cases of episcleritis. It's important to note that these cases of intraocular inflammation and episcleritis responded very well to a short course of topical steroids. Regarding efficacy, when we looked at the retinal anatomy, you can see by these 3 lines, the retinal anatomy was maintained in the RGX treated groups. You can see that the ranibizumab monthly required nearly 7 injections, while in the RGX 314 cohorts 1 and 2, it averaged only 1.2 injection over the following 6 months. When we looked at the visual acuity, you can see in the bottom graph that the visual acuity was maintained in all 3 groups. It's important to emphasize that they're not going to be visual acuity gains because these patients started off with very good vision when they entered the study, but more importantly, they were able to maintain this visual acuity with only 1 injection in the following 6 months. When we looked at the injection frequency, this is a swimmer's plot, and you can see on the left side are the number of injections given before RGX 314 treatment. The bright orange line in the middle was the first time suprachoroidal injection, and on the right was the PRN ranibizumab treatment. In cohorts 1, the injection frequency went down nearly 76%, while in cohort 2 is nearly 72%. More importantly, nearly 30% in cohort 1 did not require any supplemental injections, while nearly 40% in cohort 2. Well, the patients who did not require any supplemental injections, how did their vision do? And you can see that both their visual acuity and their retinal thickness was maintained in the following 6 months, despite not receiving any injections. And you can see before the suprachoroidal approach, they averaged nearly 10 injections and nearly 8 injections in both cohorts 1 and 2. So in summary, for the AV8 clinical trial, we can see that it was well tolerated. There was a similar incidence of intraocular inflammation observed among all cohorts with dose escalation. These were mild and resolved with a short course of topical steroids. And really the treatment, the patients had a stable vision and retinal thickness with a 70% reduction in the treatment burden. Nearly 40% of patients in cohort 2 were injection-free through 6 months. We're now going to switch gears to diabetic retinopathy. We're all familiar that diabetic retinopathy is a global health burden. We know that chronic frequent treatment with anti-VEGF therapy can improve diabetic retinopathy severity and reduce the risk of vision-threatening complications by nearly 70%. However, the majority of patients in practice are not treated due to the high injection burden. We also are familiar that a 2-step improvement in diabetic retinopathy severity scale, DRSS, has been accepted as a pivotal endpoint for clinical trials, as we've seen in Panorama and also in Protocol S. We also know from our experience that the scale DRSS 53 is really the sweet spot where we have the largest improvement. And it's important that we remember this when we look at the interim data. Now, Altitude was a phase 2 clinical trial looking at the treatment of diabetic retinopathy. RGX 314 was delivered in the suprachoroidal space, and the key inclusion criteria are patients who had moderately severe, and even mild PDR. It's important to note that no patients with diabetic macular edema were included, and patients hadn't got any treatments in the previous 6 months. Patients were treated at baseline with a suprachoroidal one-time injection of RGX 314 and then followed over the year. It's important to note that no prophylactic steroids, again, were given throughout the study. And today we're going to look at the cohort 1, the 6-month interim data. When we look at the baseline characteristics with such a small number of patients, it's important to note that the RGX 314 had more severe disease. They had a higher hemoglobin A1C. They also had higher DRSS scores, as more patients had the severe, mild, and moderate in comparison to the control. When we looked at the safety, you can see that it was well tolerated in the 15 patients in cohort 1. There were no SAEs that were, there were 2 SAEs that are not considered drug-related. And the common ocular adverse events, there were 3 cases of conjunctival hyperemia and 1 conjunctival hemorrhage. Now, there was 1 case of mild episcleritis noted 2 weeks that resolved with topical steroids. And more importantly, there were no cases of intraocular inflammation observed in this group. When we looked at the efficacy, and this is probably the most important slide, you can see on the left, the observational control that no patients improved, which is consistent with the natural history, while on the right, the RGX 314, nearly 50% had a 2-step improvement. When we looked at the time course, you can see that 33% improved at 3 months, and this number went up to nearly 50% at 6 months. Furthermore, when we looked at this group more closely, what we can see is that when we looked at the group who had baseline scores of severity scores of 47 and 53, that improvement was more impressive, nearly 43 to 57% from 3 to 6 months. Now, this is important when we put this in the context of chronic frequent anti-VEGF treatment. We know with aflibercept that's given every 8 weeks after 5 loading injections and ranibizumab every 4 weeks, that patients had about a 55% improvement in two-step scores. Very similarly, we see a similar result. When we break RGX-314 by those who had a similar severity scale of 47 and 53, we can see a similar number of nearly 57% showing improvement, while in the more severe score it was nearly 40% at 6 months. So in summary, we can see that suprachoroidal RGX-314 is well tolerated in patients with diabetic retinopathy. There was no intraocular inflammation observed at 6 months, and a single injection of RGX-314 demonstrated clinically meaningful improvements in disease severity over time. Nearly 47% of patients had a two-step score improvement at 6 months. And the future of RGX-314 is currently being studied in a subretinal approach with the phase 3 Atmosphere and Ascent programs. And we look forward to the future results of the suprachoroidal programs with both Aviate and Altitude as we look forward to the results from the upcoming cohorts and extended follow-up. Thank you for your time.
Terrific update, Rahul. Thank you very much. It's my pleasure to introduce our next speaker, Dr. Rachel Huckfeld from the Massachusetts Eye and Ear Infirmary of Harvard Medical School. Rachel is a leader in clinical research for inherited retinal diseases. She's assistant professor of ophthalmology at Harvard and also director of the Inherited Retinal Disease Fellowship Program. She'll provide an update on gene therapy for retinitis pigmentosa. Rachel?
Thank you, Diana, for the introduction, and I'd like to thank the organizers for the opportunity to be here today. And I'd also like to thank all of my co-authors who have made this work possible. My only relevant disclosure to this talk is that my institution receives clinical trial support from the company Mira GTX, who sponsors and funds the research that I'll be telling you about today. X-linked retinitis pigmentosa comprises approximately 15% of all RP. In comparison to dominant and recessive RP, it's earlier in onset and exhibits a faster progression. The gene RPGR, which is expressed in cones and rods, is responsible for approximately 75% of all X-linked RP. Animal models have supported the benefit of gene replacement or augmentation to treat this form of RP. And in recent years, a number of independent efforts have been underway to test AAV-based RPGR, subretinal, and intravitreal gene therapy in early phase clinical trials. And today I'll be telling you about the work done by Mira in this regard. MGT-009 is an open label phase 1/2 trial of AAV5 RPGR gene therapy. It was conducted at 5 locations in the United Kingdom and the United States. And the investigational product, AAV5 RPGR, was comprised of the human rhodopsin kinase promoter driving expression of a stabilized RPGR transgene. This construct was packaged into an AAV5 capsid and delivered subretinally. The phase 1/2 trial had several phases, beginning with a dose escalation cohort in which 3 different doses of the gene therapy were tested in small numbers of individuals. One of these doses was then further evaluated in children before the initiation of a dose expansion phase. In the dose expansion phase, individuals were randomized to either immediate treatment with a low or intermediate dose, or to a deferred treatment in which they were observed for 6 months before treatment with the gene therapy. Throughout this study and throughout all these phases, only one eye was treated and the contralateral eye served as a control. I will be focusing today on the dose escalation stage of the trial. And here you see some baseline characteristics. All of the participants tended to be in their 20s with a mean age of 24. And consistent with their age and stage of disease, they had fairly good visual acuity, ranging from 20/40 to 20/60. As a phase 1/2 trial, the primary outcome was safety, and we encountered primarily anticipated and manageable adverse events. There were no dose-limiting events, and the majority of AEs were ocular, related to the surgical delivery, and short-lasting. 2 of 3 patients in the high-dose cohort had inflammation that required extended steroids to treat, but there were only 2 serious adverse events. One individual had a retinal detachment related to the surgical procedure, and one patient in the low dose cohort had panuveitis. Of course, multiple efficacy outcomes were also evaluated, and today I'll be telling you about several of those. Retinal sensitivity could be assessed with static perimetry and also microperimetry. With regard to static perimetry, we used a customized grid on the Octopus 900 that oversampled the central visual field relative to the peripheral visual field. And you can see a schematic of the point locations in that figure on the left. We can assess visual field sensitivity in two ways. One is simply assessing mean sensitivity across all points tested. And the other is more of a volumetric approach, a hill of vision approach that focuses on all points within a 30-degree radius of fixation. And that red circle encompasses the points included in the hill of vision central 30-degree measure. With both of these measures, we did observe statistically significant improvement in the treated eyes at 1 year post-treatment. With the hill of vision approach, this improvement was significant both in the low dose and intermediate cohorts. I'd like to show you a little bit of the timescale for how this improvement emerged. In the graph on the right, I'm showing you the hill of vision V30 measure and pooling all patients in the low and intermediate dose cohorts. The treated eye is shown in red, the untreated eye is shown in blue. And beginning even at 3 months post-treatment, we see these two groups pulling together. And certainly at 1 year of treatment, we see improvement in the treated eye and some reduction in sensitivity in the untreated eye. We can take this approach one step further by really focusing on the area underneath the surgical bleb where the gene therapy comes into direct contact with the retina. So we can assess where the bleb was intraoperatively. We can map this location onto a visual field. And then we can volumetrically look at the improvement or the sensitivity of that area. And what you see here are a treated eye on the top, the untreated fellow eye on the bottom, and the visual field sensitivity at baseline versus 6 months post-treatment. In the upper right corner, the treated eye at 6 months shows areas of increased sensitivity shown in the blue hues underneath the area treated by the bleb, whereas we see less of a striking topography in the untreated eye. We can also look at microperimetry to investigate the macula and areas of the treated retina a little bit more carefully in a spatial regard. So these are all patients in the intermediate cohort with treated eyes on the left and untreated eyes on the right. And the treated eyes, three of four of them show at minimum stability from baseline, if not improvement. And in 2 of those eyes, we see improvement in microperimetry at 3 months, mirroring what I showed you in the static perimetry data. In contrast, all 4 treated eyes show a decrease in sensitivity over the 1 year. And when we look at the difference between treated and untreated eyes, we see the trend towards improvement. And then finally, the study included an assessment of functional vision using several mobility courses. What I want to focus on today is the paradigm shown in the middle of that schematic, where individuals are asked to navigate among obstacles, and they're asked to do so with either the treated eye or the untreated eye in varying luminance. At 9 months after treatment, when we pool together the low and intermediate dose patients, we see a statistically significant improvement in their ability to navigate this course, particularly in the lowest light setting of 1 lux. And 1 lux is equivalent to deep twilight. We see a 16-second difference between the ability of individuals to navigate the course with their treated eye versus their untreated eye. In summary, what I hope I've showed you today is that particularly the low and intermediate dose individuals treated in the dose escalation cohorts have shown us an anticipated and manageable safety profile. We're seeing signs of biologic activity across a range of functional outcomes. And we're seeing an expected spatial correlation between the areas of the retina that were treated and the areas of the retina that show improved sensitivity. There are greater numbers of patients in the dose expansion cohort, and data from those individuals will provide further insight into all of these outcomes. But based on the favorable safety profile, as well as this encouraging efficacy data, a phase 3 trial called LUMIOS is underway and enrolling now. I'd like to thank all of the participants in these trials, or this trial, and their family support, as well as all the individuals who make this work possible. Thank you.
Thanks so much, Rachel. Fabulous talk. Our final speaker of this session is Dante Pieramici. He's a vitreoretinal specialist at the California Retinal Consultants and also assistant clinical professor at the Doheny Eye Institute. He's a world-renowned clinician, surgeon, and researcher, and we're honored to have him talking about 4D-150, novel gene therapy for neovascular AMD, an update on the clinical trials. Dante?
Well, thank you very much. And I appreciate the organizers of the Innovate Summit here of inviting me to talk today about a newer gene therapy product that's being investigated now in clinical trials. And that's 4DMT's 4D-150 being looked at for the treatment of neovascular AMD, as well as for diabetic retinopathy. I am a researcher and received clinical funding from 4DMT. 4D Molecular Therapeutics is a biotechnical company focused on gene therapy for a number of medical conditions. In ophthalmology, they're looking at treatments for X-linked RP, choroideremia, as well as more common diseases such as wet AMD, diabetic retinopathy, and DME with their product 4D-150 that we're going to discuss today. I think there's no doubt, we've heard this morning, that gene therapy is going to have a huge impact in our field, not only for the treatment of inherited retinal diseases, but as the use of a drug delivery device, a biofactory, as we've heard about from our speakers today. The AAV, naturally occurring capsids, have been the #1 platform used to date. However, these suffer from low tissue specificity, low transductions of many tissues and cells in the eye, and their immuno capability or susceptibility to neutralizing antibodies. 4DMT specializes in creating new capsid variants and capsid libraries. They use diversification techniques to develop new capsid sequences and then package these in viral vectors, creating these viral capsid libraries. The platform they use consists of directed evolution, which was a 2018 Nobel in chemistry went to this technique. We're using natural selection processes to identify the most chosen viral vector capsid. They use their libraries and administer this 4DMT AAV vector capsids to non-human primates. They then analyze the tissues and select the ones that have transduced the retinal tissues the best, and then put these through rediversification and competitive selection to eventually come out with the optimal capsid. So the optimal delivery device for this capsid. And what they've come up with is R100 for retinal diseases. As I mentioned, the typical AAV capsid can't or typically don't cross the internal limiting membrane well and need to be delivered in the subretinal space. R100, however, as you'll see, can diffusely transduce not only the posterior pole, but the peripheral retina and all layers and retinal cells, including the RPE. This is some proof of concept work that's been done on the left in non-human primates showing expression of GFP that was put inside an R100 capsid. You can see that it's expressing this protein posteriorly as well as peripherally and in all layers of the retina. On the right's an in vitro human RPE cell expression model of GFP. You can see that the GFP delivered through the R100 viral capsid expressed or transduced the cells much better with much higher levels of expression at a variety of multiplicities of infection. Which brings us to this drug delivery device, the 4D-150. It's a multiplistic AAV gene therapy that uses the R100 capsid with, as you'll see, a dual transgene. This is 4D-150, and as I mentioned, it's a multi-mechanistic gene therapy approach that's being looked at now for wet AMD. It's a dual transgene. There's two in the cassette, there's two products that are being produced. The first transgene produces something that looks a lot like aflibercept. It blocks VEGF-B, VEGF-A, as well as placental growth factor. In addition, the second transgene produces a small inhibiting RNA that inhibits the production of VEGF-C. So we're blocking 4 angiogenic steps with this, potentially with this delivery system. And if we look at the overall landscape for the treatment of wet AMD, you can see that this would be a very big advantage. We look at the approved therapies here on the left, and then the AAV gene therapies, Adverum 022 and Regenxbio 314 that we've heard about. The 4D-150 would block 4 angiogenic factors. It would be an intravitreal injection and potentially a single one and done treatment. This is an expression model in human RPE cells. We can see here that the 4D-150 produces aflibercept as well as the 4DF-150 and neutralizes VEGF-A protein here at fairly low multiplicities of infection. Also, in non-human primate models, we see that given this 4D-150, there's very high levels of expression of aflibercept after 4 weeks, as measured in the aqueous humors of these animals. Additionally, there are a high number of VEGF-C small inhibiting RNA copies detected across all levels of the retina. And in this experiment, there were no evidence of uveitis or retinal abnormalities following the intravitreal injection in these animals. In a 4D-150 non-human primate CNV laser model, we can see that 2 or 4 weeks after the laser treatment, there was 100% suppression of severe CNV in all dosages of the 4D-150, ranging from 1E11 to 1E12. At 42 days after, right prior to the laser, ocular safety assessment revealed that there were no cases of uveitis or retinal abnormalities in the 1E11 viral genomes per eye. In the 3E11 and 1E12, there was some mild to moderate uveitis in a minority of the non-human primates, but no retinal abnormalities. These animals did receive prophylaxis with a 28-day course of a tapering steroid regimen. And at 6 months, there's been very little safety issues in these animals to date. This brings us to the first in human clinical trials that are now just getting underway with 4D-150 in the treatment of neovascular AMD. These are in patients that are currently receiving anti-VEGF therapy. They have to have had shown to have a response documented within the last 12 months and to have had at least 6 injections per year. This is a phase 1/2 trial, and it's really 2 parts to this trial. There's the dose escalation trial, which is a typical dose escalation. We're starting at a very low dose, 3E10 viral genomes per eye, and escalating up to 1E12 as safety parameters permit. Secondly, based on the findings of this dose escalation study, there'll be a dose expansion trial. This expansion trial will randomize patients to 2 different dosages and compare with aflibercept given every 2 months. As is typical in most phase 1 trial, the primary outcomes of these is safety. Is this going to be a safe drug to be given intravitreal of this gene therapy? But given the second phase, the dose expansion phase, we hope to get some idea about efficacy, comparative efficacy with visual acuity and anatomy, as well as pharmacokinetic and pharmacodynamic, and also looking at the need for aflibercept supplemental therapy. So I think it's pretty exciting. This study is now, these trial is underway, and there's been a few patients now recruited to the dose escalation trial. So to summarize, I think that 4D-150, as are the other gene therapies, are excited not only as a treatment for inherited retinal diseases, but as use as drug delivery systems to reduce the burden of therapy and perhaps end up with better long-term visual results in the real world. 4150 uses a targeted, evolved AAV vector R100 that was invented for intravitreal injection, has shown good transgene expression across the surface of the entire retina as well as all layers of the retina. And it's designed to have a four-pronged mechanistic inhibition approach against four separate angiogenic factors that are important in the development of neovascularization and leakage in these patients. I think to date, the non-human primate data is exciting. It shows that this gene delivery system expresses what we've designed to do, and it seems to be safe, at least out to 6 months. But the proof's in the pudding, as someone mentioned earlier today, and the phase 1/2 clinical trials are underway, and we eagerly await these results. And I certainly acknowledge all the investigators in this trial and all the preclinical investigators for the work that's been done. Thank you very much again for inviting me to be part of this very exciting meeting.
Terrific, Dante. I'd like to invite our speakers back live on camera for a panel discussion. Perfect. Nancy, first question from our audience, Tina. She wanted to know if overexpression of complement factor I could lead to any side effects. Specifically, could there be an increase in the development of choroidal neovascularization?
Yeah, it's a great question. In fact, Tina and I have been going back and forth in the chat on this. When we inhibit C3 and C5, we do see an increased rate of conversion to wet AMD that goes above the natural history that we would see in patients anyway. So it's a great question. Will supplementation of complement factor I give us a similar profile? And it really takes larger clinical trials and more patients to collect that type of data. And then in the chat, Tina and I were going back and forth that, there's no way to turn off gene therapy. So if we have long-term overexpression of CFI, what's going to be the downside of that? But right now we're exploring gene therapies that will have constitutive overexpression of an anti-VEGF agent. So, what's going to be the downside of that? Very, very good questions that we don't have an answer to.
Thanks. And then we have another question from Greg Gokami to Rahul. Are the subretinal RGX-314 results more promising than the suprachoroidal results based on the preliminary data? And that's something that, we've been talking a lot about we were talking about the route of delivery a lot this morning. And so I have another question to follow up, but Rahul, maybe you can answer that first.
Yeah, it's a great point that Greg raises. I think the exciting part about the subretinal program is that we have 3 years worth of data from the phase 1 program. And so that is, that's exciting, that's reassuring. And I think that data is what led to, the 2 phase 3 programs that are, REGENXBIO is exploring. So that part, I think, is a very exciting part. I think for the suprachoroidal approach, I think, as Dante said, we need the proofs in the pudding. And we just have really shared, the first 6 months on the first 2 cohorts. And I think ultimately we need longer term data from suprachoroidal. We need to see is the efficacy still stay there, and does the safety still is as safe as we've seen before. I think ultimately, if it does, then the suprachoroidal approach in my mind would be more promising, just because it's something that's more accessible. We can do in the office, and if you get the same results, that's an easier approach than going into the operating room. But that requires, that's a big if. We want to see how the long-term follow-up data shows up, in terms of efficacy and safety. So I think the verdict's still out. I think, the subretinal program has started earlier, and so we have longer-term data, which is more promising. But I think we're really excited to see where the suprachoroidal RGX-314 program, how these results pan out as we get more follow-up.
Rahul, just as a follow-up, one for somebody who's never given a suprachoroidal injection in the office before, what is that experience like? Does it hurt more than giving an intravitreal injection? How do patients tolerate it?
Yeah, it's a good point. I think we have I've had a lot of experience in suprachoroidal approach in treatment of uveitis from the Peachtree clinical trial and a lot of work that Clearside has done there in the past. And so I think the injection itself is very similar to intravitreal injection. It has its own nuances. I think early on when we did it, there was some pain. I think in the clinical trials, about 10% of patients did experience pain. But it's very interesting as we've learned more about it. When we used to treat uveitic macular edema, would often use subconjulitis, and that took away the pain. It's actually interesting in the gene therapy studies, we've actually stopped using subconj, and patients have actually found it to be very comfortable. And so really, most of my patients who go through it have found no difference from that with a normal intravitreal injection. So I think from a patient experience wise, it's actually something that's very comfortable, or something that's very similar to what we're used to. And I think from a surgeon's perspective, it does require small nuances, but I think it's something every retina specialist can do in the clinic. There are some small nuances that you have to kind of be aware of how to do it, but it's nothing that we've not done before, can't do. And it's something I think the learning curve, once you first see it, I think you can get through it pretty quickly and pretty straightforward. So I think that part also makes it more accessible and hopefully, reach a wider set of patients out there.
Perfect. We have an audience question for Rachel. Very exciting talk about a potential treatment for retinitis pigmentosa. Regarding safety, you mentioned there was a case of pan-uveitis. Can you give us more information about that? And do you think patients who are undergoing gene therapy need to be immunosuppressed to avoid inflammatory complications?
Yeah, thank you for that great question. We know in the subretinal AAV gene therapy landscape, or with our experience from clinical trials, that there is the potential for inflammation. And so in this trial, like many, there were perioperative steroids. In that setting, I think it's interesting that the individual who had panuveitis was in the low dose cohort. So it's not clear that this was really a dose response versus perhaps some kind of predisposing set of individual factors. I do think that immunosuppression at this point, only using steroids for the large part is important before the delivery of subretinal AAV gene therapy. Inflammation and its detrimental effects on efficacy were a big topic of discussion at ARVO and pre-ARVO meetings this year. And I think there is a question as to whether inflammation has the potential to mask efficacy. So as we work on understanding that and answering that, I think continuing perioperative steroids is a very important aspect of treating these patients.
Thanks, Rachel. And I had one more question also with regard to IRD, specifically things like RP. With a diffuse disease, this has always been a question with gene therapy given in a subretinal delivery fashion. For a diffuse disease like RP, how well can something like a subretinal injection given in a localized fashion work? And maybe would suprachoroidal delivery be something to consider here?
Yeah, it's a fantastic question too. And you raise a very apt point, which is these are pan-retinal conditions, and we are treating the posterior pole with our subretinal injections. Right now, in these early phase clinical trials, we're treating patients who have advanced enough disease that the posterior pole is where there is a target for gene therapy. But of course, if we have a safe and effective treatment, we don't want to exclude treating the rest of the retina. It's been interesting to hear today some of the discussion on suprachoroidal approach. I think for a photoreceptor disease like RP, we need to make sure that there is adequate targeting to the posterior pole with the suprachoroidal delivery and adequate expression throughout the retina. But if that were achievable and if the immune profile is favorable, then that or intravitreal strategies would obviously be able to access more of the retinal space.
Question for Dante. Terrific new idea of inhibiting more than just one target. You mentioned it's going to be delivered intravitreally. We know we had some recent increase in adverse events with the Adverum intravitreal delivery. How would this be different and potentially more safe?
It's a good question. I mean, yes, the Adverum data was a mostly in patients being treated with, it's the 7M8 AAV2 vector. Again, this vector was actually also developed by 4DMT and licensed by Adverum. So, 4DMT is actually a company that does a lot of directed evolution. And so it's a bioengineering problem in part, I believe. And, using these techniques, perhaps we can find viral capsids and proteins and peptides in the capsids that are less likely to cause severe inflammation. I think the delivery route makes a difference as well. It seems like the intravitreal route's much more inflammatory and it's going to need prophylaxis and figuring out that prophylaxis. So it's not only a bioengineering problem, it's also a clinical problem. So this is where I think that clinicians working with biotech companies and investigators together are going to try to figure out how best to reduce the chance of these bad complications that are probably also dose dependent. As we saw in the Adverum patients, the ones in the highest dose and in the diabetic patients had the most severe reactions, although there were some inflammatory reactions also in AMD patients in the high dose group as well. So, it's a very exciting time. I mean, I hear these talks this morning and I'm very excited by the possibilities. There's lots of things that can be tweaked. The bioengineering of the capsids and the cassettes, the transgenes that are used, the delivery route, the prophylaxis. So it's really going to require team effort between clinicians and biotechnical companies and research, basic science researchers to figure this out. But I think it has a super bright future, not only for inherited retinal diseases, but I would anticipate, 20 years from now, many of our agents, clinical treatment agents, are given by gene therapy delivery systems.
Perfect. On that positive note, I'd like to thank all of our outstanding faculty today. Thanks for participating. And we'll go to our next session led by Dr. Priti Mruthyunjaya and Natalia Calloway. They'll give us an update on new developments.
Thank you, Diana, and thanks to our speakers on the two previous exciting sections. As vitreoretinal surgeons, there's nothing that we like better than improving our armamentarium in the operating room and finding better ways to do the delicate work that we do. We'll be having two very exciting talks this morning. The first is by my good friend, Dr. Yannick Liederman, who's an associate professor of ophthalmology at the University of Illinois at Chicago, and he'll be talking about artificial intelligence guided ophthalmic microsurgery. Is this disruptive tech or an extinction event? Sounds good. Yannick, take it away.
Good morning. I'm Yannick Liederman, and I'd like to thank the program directors, and especially Dr. Mruthyunjaya, for inviting me to speak on artificial intelligence guided ophthalmic microsurgery. These are my disclosures. Of note, no commercial entity supported this work. However, I should point out that I am one of the co-founders of Microsurgical Guidance Solutions, which holds intellectual property and commercial rights to some of the technology described here today. So let's begin with an examination of our microsurgical environment to try and frame opportunities for digital enhancement. In our current paradigm, the surgeon controls the instrumentation and receives feedback in turn, and likewise interacts with the visualization system. A feedback loop allows for direct interaction of the surgical instrumentation with the visualization system, and this imaging instrumentation feedback loop confers the potential for greater precision and safety. This approach is increasingly used in consumer automotive, rail, robotic, and aviation applications. So let's start with a working definition of surgical guidance from a surgical data science perspective. The first component is integration of information from imaging modalities, our instrumentation, and the surgeon. In our case, data analysis is executed using a deep learning neural network and computer vision, followed by output to the surgeon and instrumentation that has to be able to enhance instrument performance or support surgical decision-making in real time. Let's start with an overview of a few of the milestones for AI clinical applications in retina. So it was almost 5 years ago when the potential for AI-based automated screening of fundus photos for diabetic eye disease became widely known. A related communication published in Nature from a broad group of AI scientists and biomedical researchers at Google sparked the imagination of countless vision scientists when they found that deep learning can extract new knowledge from retinal fundus images. In other words, they were able to discern features not previously thought to be present or quantifiable in retinal images. For example, their deep learning neural network was able to predict patient age, gender, smoking status, systolic blood pressure to within about 11 points, and perhaps of greatest clinical significance, to some degree, the likelihood of major adverse cardiac events. This was really groundbreaking at the time. Similarly, other groups applied machine learning to OCT data, here identifying, quote, distinct topographic and temporal patterns that allow for prediction of eyes at risk for AMD progression that we were not able to recognize before. So now I'd like to move on to some of the tools that we've developed for surgery of the posterior segment. Here's an overview of our technology pipeline for VR surgery. Imaging is acquired from a commercially available digital stereo microscope or optical microscope with HD camera, and a neural network performs image processing. Then a set of phase-specific digital surgical tools is activated accordingly. The network output is then injected back into the surgical frame or relayed to our instrumentation. I'd like to talk about 4 categories of tools this morning: AI-mediated enhanced visualization, surgical templates, tissue and tool tracking, and very briefly, laser delivery. Here's an example of image enhancement. The video on the left demonstrates suboptimal visualization from media haze. AI-mediated image processing yields an improved view of the surgical anatomy. Note the retinal vessel immediately proximal to the forceps tip. It's difficult to discern in the unenhanced image, representing a potential source of complications during peeling. Similarly, during cataract surgery, image enhancement, shown on the right, improves visualization of the margin of the capsula rhexis in comparison with the unprocessed view on the left. Here's a sample of tool and tissue tracking. The locations of the vitrectomy probe, optic disc, and macula are being tracked in real time. The labels are shown only for network performance demonstration purposes. This instrument and tissue tracking is performed in the background. In this surgery for complex diabetic retinal detachment, the macula, optic disc, laser probe, and a retinal break are simultaneously being identified and tracked by the network. Laser spots at the margin of the break are also identified as they are applied, and this serves as the foundation for semi-automated delivery of retinal laser. Note that in spite of compromised visualization associated with surgery under air, the network maintains excellent performance. AI-based collision avoidance methodologies have outstanding potential in VR surgery. The VIT probe, detached retina, and area of scleral depression are tracked, and a proximity alert is provided when the cutter is at risk of interacting with mobile retina. Now, while this may not be necessary feedback for the experienced surgeon, the real value in these data is the potential for feedback to the fluidics engine and automated modulation of fluidic parameters to improve performance and reduce the likelihood of iatrogenic retinal breaks. So in summary, we've developed an automated pipeline capable of tracking the location of surgical instruments relative to the retina during vitreoretinal surgery in real time using deep learning and computer vision. We've achieved effective instrument localization with CNNs, computed the distance between surgical instruments and the retina, and implemented a framework for surgical guidance, and achieved this performance in real time. So when Prithvi was kind enough to invite me to be a part of this outstanding program, he suggested a really provocative question. Will AI make clinicians and surgeons in our field effectively irrelevant, or perhaps glorified technicians? So to begin to answer this question, let's take a look at one of the more straightforward applications of AI, image classification and recognition. Before we can extrapolate the capabilities of AI-based image interpretation to our field, it's helpful to consider some of the important differences between natural and medical imaging. So first off, they look different. Natural images in the libraries that serve as the gold standard for training networks are high signal, high noise, in contrast to most of our medical imaging. And it's clear that AI is much better than humans at some image-based tasks. So let's look at an example here. Have you found Waldo? Not yet? Well, let's make a bounding box, see if that makes it a little bit easier. Now have you found him? So you sequentially scan the many figures in this image, essentially first performing a classification task while looking for features that distinguish Waldo. Our AI network performs these tasks in parallel, achieving the outcome much more quickly in a fraction of a second. We are definitely much less efficient at these kind of tasks, performing them sequentially. In fact, if you're so inclined, you can even find a Waldo-labeled training data set in GitHub, so go crazy for UCS people. So some other classification tasks continue to present a challenge. You probably won't have too much trouble with the muffin versus chihuahua task on the upper left, or differentiating a puppy from a bagel, but these can be surprisingly challenging. So this brings us to another critical difference among natural and medical imaging. The stakes in medical imaging are really high. Remember the referable DR screening tool we discussed earlier? Adoption was significantly hampered by hurdles associated with real-world implementation. So this is Jeff Hinton, which those of you interested in AI are familiar with, and let's see what he had to say about things. What's the role of AI in biomedical imaging? I think if you work as a radiologist, you're like Wile E. Coyote in the cartoon. You're already over the edge of the cliff, but you haven't yet looked down. There's no ground underneath. People should stop training radiologists now. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists. So this was almost 6 years ago. And I'm certainly not criticizing Jeff Hinton. He probably has more creativity and cognitive compute capability than I do by several orders of magnitude. But the point here is that the tasks we perform as clinicians are hard, and the stakes are really high. So maybe a more nuanced view with relevance to clinical medicine is that of human-centered artificial intelligence, whereby AI learns from human input and collaboration, focusing on algorithms designed to exist among a larger human-based system. And so to paraphrase my collaborator, Darwin Yi, really the mission is to create data science tools that can help make clinicians more effective through the use of interpretable models. I'd like to acknowledge my partner and PhD student, Raj Nespolo, as well as the rest of our academic research group. Thank you.
Thank you, Yannick, for that very insightful and future-looking talk. Our next speaker is Dr. Caroline Baumel, who's a professor of ophthalmology at the Tufts Medical Center in the Department of Ophthalmology. She'll be discussing the future of enhanced surgical visualization. Caroline?
I'm Caroline Baumel from New England Eye Center in Boston, and I'll be reviewing the future of enhanced surgical visualization. These are my disclosures. Visualization may be the most critical component of retinal surgery. To give a little background, it was only in the 1960s that the foot pedal was invented, along with the motorized operating microscope with zoom. Wide-angle technology followed in the 1980s and 90s, and now we're in this new era of technological advancement with digital visualization. In contrast to the surgeon operating through the binoculars of a standard operating microscope, recent advances now allow surgeons to view procedures with a 3D heads-up display, such as that provided by the Ingenuity 3D visualization system by Alcon or the Artivo by Zeiss. There are also new augmented virtual reality display systems, such as the Bionics 1 and the upcoming Orlens from Ocultrex. Some of the advantage of digital systems over standard operating microscope during retinal surgery may include these key features: enhanced stereopsis, wider depth of field, increased magnification with a larger field of view, decreased endoillumination requirements, which is safer to prevent phototoxicity, the ability to digitally enhance images and use different filters to enhance vital dyes and tissue planes of the retina, combining the retinal imaging with OCT and using it as a guide for complex procedures like subretinal gene therapy. Also, these systems may provide improved surgeon ergonomics and create an immersive experience in the operating room for the staff and for teaching. One of the longest players so far has been Ingenuity from Alcon with a 3D heads-up display. You can see my friend here, Dr. Maria Barakal, using this system to fix a severe diabetic tractional retinal detachment. This shows the large high-definition screen and surgeons and observers in 3D glasses for this immersive display. In addition to the key features that I mentioned about digital technology, there's an opportunity in digital systems for personalized color profiles, and in this paper by Dr. Rishi Singh's group, the optical parameter profiles were evaluated to improve visualization of epiretinal membranes using the Ingenuity. This is the Zeiss Artivo 800, which can have 3D heads-up display or the standard operating microscope option, as well as integrated OCT imaging. A different approach is being used by Bionics 1, which is an augmented reality visualization system designed to replace the operating microscope, and this is based on fighter pilot technology. The components of the Bionics 1 include this very important surgical headset for this augmented virtual reality display, as well as a touchscreen, a console, and a digital camera with LED illumination. Some of the current key features include heads-up display, which is ergonomically favorable for the surgeon, as well as the surgeon can control and optimize the 3D immersion by use of a head gesture or the foot pedal. The display can change from a see-through display to an opaque display where one is imaging the surgical field. As well, there can be customized data injection into the surgical visualization, as shown here on the bottom left, where the OCT images are also seen in the surgical field of visualization. This is a list of some of the core technologies with Bionics 1. One of the unique features of Bionics 1 is that the surgeon uses head gestures combined with pressing on the foot pedal, and this may be later replaced by voice commands, but this is done to change focus, autofocus, and zoom. There's also a feature called Pan or Digital XY, where one can scroll within the field and magnify without moving the patient's eye. And again, this is done with head movements. This is demonstrating some of the head movements. You can see on the left that I'm using my head to focus and zoom as visible on the video screen behind me. And then in the upper right, my friend Dr. Fortune is using head movements to pan, and on the bottom right, that was my view as the surgeon using focus and pan to optimize my image during laser. We wanted to evaluate the relationship between various filters for image enhancement and parameters for ILM and ERM peeling and determine the optimal parameters. And here I'm peeling an internal limiting membrane with brilliant blue. Currently the red filter is on for image enhancement, and this will change at various times during the imaging. Also we'll be changing the white balance and changing the digital and camera gains. So now the blue filter is on, you can see in the upper left, and then the green filter. And with various combinations of light, we found that the red filter and the neutral filter best enhance the image with brilliant blue dye. As well, another option is to have digital consultation, and this can be done in this case with myself and Dr. Caldez.
I usually like a 3D circle
using an
because
HDMI cable and a laptop,
sort of person.
and I'm able to view his screen.
But obviously,
he is
in a small
imaging
hole, I
directly.
think we've got enough peel here. What do you think?
And so we were able to discuss his case real time. To summarize, we have novel alternatives to traditional operating microscopes based on digital technology, and this really has amazing potential to add to our surgical armamentarium. Some of the potential add-ons that may happen include adding a cursor to the imaging screen, integration of OCT and other imaging technology, and using voice commands. It was a pleasure to present this today. Thank you.
Excellent. Those were two really fascinating talks about newer technology. And I think one of the challenges that we have with new changes in our surgical suites is the cost, but also the implementation of them in the setting of our usual surgical routine. So bringing in new technology sometimes adds layers of extra time, training of the staff, and just familiarity with what we're used to, and now adding another layer of technology. So it's almost like information overload sometimes that surgeons discuss as being concerns or issues. So at this point, we are going to move to our final section, which will be our very exciting area of innovating within your practice. In order to do this, we are going to switch our feeds for compliance issues. So on your screen, if you look below, there is a section with a play button that says non-CE presentation. If you wouldn't mind all clicking to that screen, then we'll hear 2 words from our sponsors, and then we'll begin our final section. Thank you very much. You can all click that bottom screen now. Thank you.
For over 15 years, treatments for DME and NAMD have only targeted one pathway. Until now. Introducing a new treatment, targeting VEGF and ANG2. Two pathways, one choice. Vabysmo, where two worlds meet.
Please see additional important safety information in the full Vabysmo prescribing information.
What is it that moves patients? And motivates our scientists? And inspires you? At Regeneron, we're deeply committed to ophthalmology and our work in wet age-related macular degeneration, diabetic macular edema, diabetic retinopathy, and macular edema following retinal vein occlusion. Our culture of innovation and industry-leading commitment to R&D across all disease states has led to 9 FDA-approved products, providing a strong foundation for future success. Working together, we're committed to helping people with their sight, opening a world of possibilities for patients, scientists, and healthcare professionals.
Welcome everyone to section 4, the final section of Innovate 2022 today. This is the section Innovating in Your Practice. We're really excited. For those of you, thanks for migrating over here to this non-CE section of our discussion today. I'm joined by my friend and colleague, Dr. Natalia Callaway. She's a lead medical director at Roche Genentech and also a colleague of mine over at Stanford University in the Vitreoretinal Surgery Division. And we have a really exciting set of talks today that we're going to be going through. Leading off is my friend and colleague, Dr. Diana Do, who's a professor of ophthalmology at the Byers Eye Institute. She's going to be talking to us about clinical trials, specifically when they don't go the way you want them to, and what role clinicians can play in helping to shape clinical trial development. Diana, please take it away.
Thank you, Stephen. It's my pleasure to join everyone again. This time, I'd like to give an update on when the clinical trials results don't always go as planned. These are my disclosures. We know that the road to FDA approval of a new novel medicine is quite a long one. In fact, there are many potential medicines that are in preclinical stages, but the ones that advance through phase 1, 2, and 3 clinical trials are much smaller. And in fact, there is a big investment that biopharmaceutical companies make in order to develop a potential agent that can help patients and is available worldwide. Less than 12% of candidate medicines that make it through phase 1 will actually be approved by the US Food and Drug Administration. Although we've had many great successes in retina, we've also had a few failures. Notably, Fovista failed in their pivotal phase 3 clinical trials several years ago. High-dose ranibizumab did not meet its primary endpoint. Even more recently, KSI 301 did not meet its primary endpoint in the DAZZLE clinical trials. We also learned that in geographic atrophy, pegcetacoplan showed positive data in one of the pivotal clinical trials, but yet the second pivotal clinical trial did not meet its primary endpoint. So there are numerous clinical trials that don't always go as planned. What went wrong? Well, there are a lot of things that could go awry, and of course, hindsight is always 20/20. But the most common reasons for clinical trials not to meet their primary endpoint include the inability to demonstrate efficacy. And that can occur with a flawed study design, inappropriate statistical endpoints, or an underpowered study. In addition, another cause of failure is inability to demonstrate safety. For example, more recently, bevacizumab we know is used worldwide, but Beovu, which recently was FDA approved by the Food and Drug Administration, did not successfully launch because of safety concerns that arose after it was marketed. And of course, safety is utmost concern, especially in retina, where we have other effective anti-VEGF agents that are on the market. But is failure bad? Actually, not really. In Silicon Valley, we know that failure can actually lead to greater success later on. Because in order to innovate, we need to try. And most of these attempts might fail, but ultimately it can lead to greater success. No innovation occurs without failure. The most important thing is when results don't go your way, how does the company respond to this? Well, usually we have to scrutinize and study the data to understand why the results didn't go as planned. We need to learn from these mistakes and apply new knowledge to future studies. We might want to negotiate with the FDA. For example, Apellis is negotiating with the FDA to look at month 18 results for their candidate complement inhibitor in geographic atrophy. And they recently submitted to the FDA these longer term results, which showed beneficial effects for their candidate drug. And finally, companies need to move forward with new clinical trial plans or additional studies to truly test their candidate molecule to see if it will pass the efficacy and safety endpoints. Thank you again for allowing me to share this information, and I look forward to our discussion ahead.
Thank you so much, Dr. Doe, for that great talk on a highly relevant topic. It is my distinct honor to introduce Dr. Thomas Chula, who is the Chief Medical Officer and Chief Development Officer at Clearside Biomedical, where he supported the approval of the first suprachoroidal therapy, Zipre. He previously was at Spark Therapeutics, where he led medical strategy to support the approval and commercialization of Luxturna. As a board-certified ophthalmologist and retina specialist, he remains a volunteer clinical professor at Indiana University School of Medicine.
Thank you, Natalia. As a retina specialist, I'm excited to be part of a potential paradigm shift in the way we deliver retinal therapeutics. With one approved and multiple suprachoroidal therapies in trials, this morning I'll cover several key topics for clinicians, including multimodal imaging that demonstrates targeted compartmentalized delivery via suprachoroidal injection, drivers of durability, drivers of flow to the posterior pole, and suprachoroidal therapies currently undergoing clinical trial. Next slide, please. My disclosures are shown on this slide. Next slide, please. I may make some forward-looking statements and encourage you to view the Clearside website for more information. Next slide. And you can start the video. This video clip shows CLS-AX, a tyrosine kinase inhibitor, being injected in a clinical trial patient. The setup is essentially identical to an intravitreal injection with a lid speculum. The dark orange betadine is pooling at the bottom of the eye. You'll note that the injection occurs at the pars plana at the same location as an intravitreal injection. You'll see the plunger being depressed as medication is injected into the suprachoroidal space, and the patient appears comfortable without extraneous movements. Next slide, please. Next, with several novel imaging modalities in our lab, I'll show that suprachoroidal injection results in targeted deliveries to affected chororetinal tissues for potential efficacy benefits, compartmentalization away from unaffected tissues for potential safety benefits, and bioavailability. The chororetinal tissues are essentially bathed with therapy. Next. In this imaging study, ex vivo porcine eyes were injected intravitreally and suprachoroidally with 100 microliters of dye, and then immediately frozen. On the left, after intravitreal injection, there's a bolus of dye in the vitreous cavity. In contrast, on the right, after suprachoroidal injection of the same volume of dye, there is spreading from the scleral spur anteriorly to the macula posteriorly. Next, please. This suprachoroidal compartmentalization can yield high levels in posterior tissues and low levels anteriorly, which has potential safety advantages. In this example of compartmentalization from a rabbit pharmacokinetic paper we just published, levels of CLS-AX were highest in the RPE choroid inner sclera, as noted by the black bars, and lowest in the vitreous, as noted by the white bars. This compartmentalization relationship was maintained out to 182 days, or 6 months. Next. And you can run this video. In this study, we compared suprachoroidal injection to intravitreal injection in ex vivo porcine eyes. Here we injected 100 microliters of dye that fluoresces under UV light. For this intravitreal injection, you can see the bright fluorescence of dye in the syringe, but no fluorescence in the eye itself as the dye is injected because the pigmented choroid and RPE blocks light. When the same volume of dye is injected suprachoroidally, as is being shown now, you can immediately see spread circumferentially and posteriorly just beneath the sclera of the eye, but above the pigmented choroid and RPE. Next. And you can run this video as well. This is a similar video clip showing suprachoroidal injection of India ink into a human cadaver eye. Note the circumferential and posterior spread just beneath the sclera of the eye. Next. Very much like the last two videos, in REGENXBIO's ongoing clinical trial of suprachoroidally injected RGX-314 gene therapy, thermal imaging shows a diffusely spreading temperature gradient during the injection procedure. For orientation in all four images, Room temperature objects such as the injector and lid speculum appear dark, respectively on and around the eye. From the upper left to the upper right, to the lower left, and then to the lower right, you can see the temperature gradient of the spreading injectate progress acutely. This confirms placement of therapy suprachoroidally. Next. Next, I'll highlight drivers of durability. In preclinical studies, particles, whether relative insoluble drugs in suspension, DNA nanoparticles, and AAV all have durability in the suprachoroidal space. This is likely due to their size relative to the pore size of the choriocapillaris, which is approximately only 6 nanometers. Other factors also play a role, including solubility. Next. Preclinical data supports the durability potentials of small molecule suspensions in the suprachoroidal space. You'll note that the corticosteroid triamcinolone acetonide, the tyrosine kinase inhibitor axitinib, a plasma kallikrein inhibitor, and a complement inhibitor all showed multiple months of durability in our rabbit pharmacokinetic model. Next slide, please. Next, I'll highlight drivers of posterior flow to the macular region. This important non-human primate study shows that intraocular pressure is greater than the anterior suprachoroidal space pressure, which in turn is greater than the posterior suprachoroidal space pressure. These pressure gradients normally drive uveoscleral outflow and also maintain the suprachoroidal space as a potential space. In the upper left retinal image, you can see indentation of a pressure measuring cannula in the suprachoroidal space underlying the macula. The table demonstrates these pressure differentials numerically, while the graph shows nearly parallel lines depicting how these pressure differentials are maintained regardless of the intraocular pressure. Consequently, when an injectate enters the suprachoroidal space, the intraocular pressure drives that injectate circumferentially and naturally towards the lower pressured posterior suprachoroidal space. Next slide, please. These OCT images demonstrate opening of the suprachoroidal space after injection. In the top image, which was recently published, the blue arrows show opening of the anterior suprachoroidal space in a clinical trial subject immediately after injection. In the bottom image, which we also recently published from a DNA nanoparticle experiment in rabbits, the blue arrow highlights the post-injection expansion all the way posteriorly to the optic nerve head, supporting the potential to acutely target submacular tissues. Next. These figures are from a poster we presented at ARVO last year. They show that the posterior in red and peripheral retinal drug levels in blue in a rabbit model are similar, both at the level of the retina on the left and at the level of the RPE choroid inner sclera on the right, out to 84 days. This vividly demonstrates the potential to address macular disorders with an in-office suprachoroidal delivery system. Next. The distribution, targeting, and compartmentalization characteristics we just discussed were associated with a successful phase 3 trial and recent FDA approval of XIPERE. It represents the first approved therapeutic delivered into the suprachoroidal space. Importantly, it was approved for the treatment of a macular disorder, uveitic macular edema. Next. This slide shows important safety information about XIPERE. This is covered in the prescribing information. Next. Finally, I want to briefly highlight therapies and indications currently in clinical trials using in-office suprachoroidal delivery. Currently, there are 6 clinical studies evaluating 4 suprachoroidal therapies. Arctic is sponsoring a phase 3 trial of triamcinolone acetonide for uveitic macular edema, as well as a phase 1/2 trial in diabetic macular edema in China. Clearside is sponsoring a phase 1/2 clinical study of a tyrosine kinase inhibitor, CLS-AX, for the treatment of neovascular AMD. Aura is sponsoring a phase 2 study of a virus-like drug conjugate for the treatment of choroidal melanoma. And finally, as you heard earlier, REGENXBIO is sponsoring phase 2 studies of a gene therapy biofactory for the treatment of neovascular AMD and the treatment of diabetic retinopathy. In summary, I've covered the key attributes of suprachoroidal delivery, including targeting of affected tissues for potential efficacy benefits, compartmentalization away from unaffected tissues for potential safety benefits, drivers of durability, drivers of posterior flow, and I also highlighted some suprachoroidal therapies in development. We look forward to more progress, and I thank you for your attention this morning.
That was a wonderful talk. Thank you so much, Tom, for that. Great to learn more about suprachoroidal delivery, and very much looking forward to discussion with the panel discussion here in just a couple of minutes. As a prelude to the panel discussion, I'm actually just going to introduce briefly what we're planning to do for our live event, October 2nd, at the American Academy of Ophthalmology meeting. These are my relevant financial disclosures. So we're very much looking forward to, let me go back 1 second here. There we go. Very much looking forward to having everybody in person. So when we initially envisioned this event back in 2019, we were planning to have our first in-person event in 2020, and obviously the world turned upside down. Weren't able to do that. So we're very much looking forward to seeing everyone face to face. What we're planning for the innovation in your clinical practice section is to focus on panel discussions with audience involvement. And one of our main goals for the Innovate meeting is to fill an unmet need, we think, in the retina education ecosystem. Specifically, how can we get more clinicians involved in industry and innovation? How can we equip each other with tools to be successful? So a few of the topics that we're potentially going to be discussing are things like moving from clinical practice to industry or hybrid careers, maybe working part-time in academics, part-time in industry, part-time in private practice and industry. Other things that we'd like to discuss would be launching your own startup. So since we've started this meeting, I've had a number of retina docs come up to me and ask questions about practical matters for how you start and manage a startup company. And even today, we heard Yannick and others mention that they have intellectual property and they're co-founders in companies with novel technologies. We want to foster this in the retina community and work together to change practice for the better for our patients. So identifying mentors is going to be a key part of any successful career. So we want to talk a little bit about mentorship. Practical things like designing a pitch deck. If you're fundraising and you have a startup that you're co-founding, how do you bring money in? How do you successfully get from the starting point to moving a product into development? IP, so intellectual property and regulatory, we'd like to touch base with that. And then finally, dealing with failure. And I think Diana's talk today was a perfect segue into that, where she mentioned 88% of drugs that go into phase 1 never get across the finish line. And so failure is a very important part of industry. It's something that's much different than clinical practice, where we're typically dealing with therapeutics and drugs that have already been vetted, that have gone through phase 1, 2, and phase 3 development programs. Failure is something that we need to think about from an industry standpoint. So would really encourage you, again, it's October 2nd, 2022 at Academy. It's going to be the evening of October 22nd. Please mark it on your calendars and do plan to join us for what promises to be a small group session, intimate learning with audience participation as we do innovation and entrepreneurship together as a retina community. So now I'm going to go ahead and invite the speakers and co-moderators to come back on screen, and we're going to kick off our panel discussion, which we're going to conclude today's session with today. Really looking forward to this discussion. I actually wanted to kick things off with a question for Tom. And, Tom, as we've heard over the last couple of years about gene therapy holds so much promise. You've published extensively on it. You've been a leader in this field, both at Spark and now you work at Clearside, interacting with other companies like REGENXBIO. Obviously, inflammation's been a big problem. And so we have therapeutics that are poised to really transform the field, but now we also have this concern about how do we go from a one and done therapy, but now, things like panuveitis and can't shut off and, all the things that are now concerns and kind of clouding the field. Suprachoroidal delivery really looks like it holds promise to help us get a scalable gene therapy program, something that's really, really exciting. However, I want to play devil's advocate a little bit. And I've heard from talking to people at suprachoroidal delivery, there are some challenges. Can you speak to some of the idiosyncrasies of using a suprachoroidal injector versus an intravitreal injection, which is really straightforward?
Well, that's a great question, Stephen. And again, thank you for inviting me to participate today. It's really an honor. So we're all used to doing intravitreal injections. It's one of the most common, I think, Medicare procedures now every year. And we've gotten really good at it and we've gotten very quick at it. And I like to say that we do it before the patient can say ouch, right? We do it very quickly. And one of the aspects of training on suprachoroidal injections are actually untraining physicians some of their habits with respect to intravitreal injection. So for example, with suprachoroidal delivery, you do have to hold the needle perfectly perpendicular. You have to create a dimple, and then you have to inject slowly because you're opening a potential space. And that's a lot different than intravitreal injection, where you try to do it as quickly as possible and the angle doesn't matter. And we actually have a synthetic eye that we train on. And as you probably know, Bausch Health is commercializing Xipere, and we've helped them with their training program, which they've now scaled. And they will send you one of these synthetic eyes, and each quadrant has a different thickness, and they'll train you on it. And it really is learning how to hold the needle perpendicular, creating a dimple with pressure, and injecting slowly. Those are the key steps. And if you don't do that, the injection may not go very well. The patient can feel some discomfort if you go too fast. You may not be able to deliver the entire contents of the dose or of the syringe. If you don't hold it perfectly perpendicular and don't apply pressure. So those are some of the features that are different. And I would encourage anybody who wants to do an intravitreal suprachoroidal injection to take the time to go through the training program. It's fairly quick, but it's really unlearning how to do an intravitreal injection when you approach a suprachoroidal one.
Great.
And I think that speaks to any new drug delivery devices or procedures. It's an opportunity for us as retina specialists to learn new procedures, but we have to be open to learning that, because many of these new techniques are exciting and promising, but do require us to kind of go back to step one and evaluate how is this specific procedure done most safely, most efficaciously, most reliably. And that may be a trend through many of the drug delivery devices and processes we see coming out or into the future. I have a question for Diana. Thank you so much for the wonderful talk. When you spoke to some of the elements that can lead to a negative readout. I don't like to use failure because I agree with you. I don't think it's a failure to investigate. So a negative readout, how do you as a clinician evaluate which reason you feel or which reasons you feel play into that specific molecule or device or surgery's negative readout? How do you look at the data and decide, is it a design flaw? Is it that the molecule didn't work? And kind of what perspectives would you share with the audience on that evaluation?
Thank you, Natalia. I think one of the most common reasons a pivotal phase 3 clinical trial has a negative readout is that there are some changes between the phase 2 and the phase 3. Ideally, you plan the pivotal trial on strong data that you've acquired in the phase 2 comparative head-to-head trial. And if the phase 2 has a positive readout, you don't want to change many of the factors that were included in the phase 2, the inclusion exclusion criteria of the patients. Because if you keep things identical, it can be more predictive of a good outcome. And we've seen in some studies in the past, for example, for Vista, they did change some of the inclusion criteria between the phase 2 and phase 3, and that might have led to the negative readout. So I think it's important when we're key opinion leaders and advising these companies on clinical trial designs, keep what works. Don't change it if it's not broken.
That's great. And I'm going to actually ask Tom and Natalia the same question. And I'm going to be nicer to Natalia and put you on the spot, Tom, because I'm going to ask you first. And that is, both of you are on the industry side. And so I want you to put your CEO hats on. You've been managing a clinical trial in, let's say, phase 3, kind of late stage development. And we know these cost 9 figures, right? 100 million plus to run a global phase 3 program. And I want you to imagine that you get some negative top line results coming across your desk. And thinking from the industry side, maybe can you give us a few words about how you think about a negative result or a less than optimal result, and how you kind of then take those results and share them with the retina community, also thinking about how to educate and move the field of retina forward. So Tom, if you could maybe take a stab at it, and then Natalia, I'd love to get your thoughts as well.
Sure. Well, I just want to echo a little bit of what Diana mentioned. Some of the studies I've read, only 12% of therapies that make it into a phase 1 study are eventually approved or successful and approved. So there is a funnel, and we actually like the failures to occur early. So it's best, we often test multiple molecules preclinically, and that's ideally when we want them to fail. And if not, better to fail in phase 1 than in phase 2, and better to fail in phase 2 than in phase 3. But occasionally it does happen that a drug makes it into phase 3 and fails. And there can be a lot of different reasons for it. Sometimes it's just the biology. Sometimes the phase 2 studies are underpowered. They have a high alpha level. And then, sometimes big companies roll the dice and do a phase 3 trial, and you get failure. And so, I think when you have failure, I can tell you that being on the industry side, there's a lot of transparency, especially in a public company. Public companies, must report their results. I think public companies are generally very transparent. And when you have a failure, oftentimes there's a lot of work being done at the company to try to figure out what happened. There's a lot of replaying the tape, so to speak. And I think ultimately, after a company does their investigation, they're often fairly transparent with the retina community. And again, it can be a matter of trial design, or having an underpowered phase 2 study that informed a phase 3 study. It could be the biology. Sometimes designs are changed. We're taught not to do that because a phase 3 trial is really supposed to be confirmatory. But sometimes designs do change, often for what at the time might seem like a good reason. But I think companies are transparent, and I think sharing these negative results with the retina community can foster further innovation. We all learn a great deal from our failures.
I would agree 100% with what both Diana and Tom have said. It's never what we want on any side of the token, because all of us are working to develop the next therapies for patients. To see a negative readout after all that work, and certainly, I joined Roche Genentech when we were reviewing the tapes, in Tom's words, for lampalizumab, and trying to understand exactly what happened and were there any opportunities to change or learn more. And we go through the process that Diana discussed in her slides. Is there anything we could have done, or is this a molecular biological failure? And I view my role in drug development, particularly as in designing clinical trials, is to clear the path for a molecule or a surgery or a device to show what it can do, so that there really is no discussion that, oh, maybe this impacted it, or it should have been designed differently, or we didn't look at this data properly, that the outcome is the outcome. I would certainly echo the emphasis on early stages and the importance of the phase 1 and phase 2 data. I think a lot of what you see in a phase 3 trial is likely already in your early phase data. It's just the question of, did you power it properly? Did you look at that endpoint? And did you design the study to give that answer? Because you'll only get the answer from such a small cohort to the questions that you specifically ask in the earlier phases. But in the end, I think that all of us are in the business of moving forward the frontier of retina, and that, again, I don't view it as a failure. It's the scientific process. And as Tom mentioned, companies, at least the ones I've worked with or in, have full transparency, and even a negative result is an important contribution to the literature and to our understanding of a disease.
Yeah, and that's great, and that both of you said that, because I think that trust is everything, especially in a community like retina, where there's really not a lot of retina specialists. Everybody knows everybody, and And that transparency that you both mentioned, I think is such a vital part of what we do and what we're attempting to do as we're looking for cures and better treatments for our patients. I guess as a final question, as we wrap up this panel discussion, I want to turn it back to you, Diana, with a final question. That is, as a key opinion leader in the field, we've got a lot of retina specialists joining us today, actually from around the world. And as we're thinking about, a lot of us aren't in industry, we're not running companies, but we are participating in these trials. How do you, as a retina specialist, as a key voice in this field, how do you work with companies? How can we work with companies to help as we're thinking about clinical trial design, minimizing negative results, not failures, but negative results? How do you interface? How can we do better as a retina community?
The retina community, fortunately, is very collaborative with our industry partners. I think keeping an open dialogue using our clinical expertise is what they want to hear. And companies want to hear the truth. So I think it's best using our clinical knowledge with pharmacotherapy to tell them things that they might not want to hear, that their drug doesn't seem to work or their study design isn't the most ideal to evaluate this question. Because if we share our honest opinions, they'll respect it because it might give them better insight. And I encourage all retina specialists to, be thoughtful, be honest with our industry partners because they'll appreciate that.
Wonderful. Thank you so much to our speakers. Thanks, Diana, Tom, and Natalia for joining me today. This is going to be concluding our session here at Innovate 2022. The session 1, again, session 2 is October 2nd in Chicago, Illinois. And so there's a reminder for those of you who are looking for CE credit. You're going to get an email with a little bit more information on exactly where to go for that. And then I wanted to also end with thanks to each of our speakers. This is not a meeting. Were it not for your expertise. So thanks for your time, your expertise, and your knowledge that you've shared with us today. And of course, for our sponsors, industry, without Genentech, Novartis, Regeneron, Apellis, Bausch & Lomb, Iveric Bio, Resolute, Regenex Bio, Korea, without each and every one of these sponsors, we wouldn't be able to innovate. It's so important for us to acknowledge how thankful we are as a field, how thankful our patients are for your support and for the work you're doing to make the future brighter for all of our patients. So again, thanks everyone. Have a wonderful weekend. Please mark on your calendars to see us again October 2nd. Take care.